Neurology quiz number 75. Describe the clinical features, pathogenesis, and treatment of narcolepsy. Narcolepsy is a disorder of rapid eye movement sleep characterized by excessive daytime sleepiness. Narcolepsy is of two types according to the ICSD-3 classification. Narcolepsy type 1, previously called narcolepsy with cataplexy, and narcolepsy type 2, previously called narcolepsy without cataplexy. Clinical features: narcolepsy type 1 has a prevalence of 1 in 2000 with a bimodal age of onset between 15 to 35 years of age. Prevalence of type 2 is unclear as it is more heterogeneous and pathophysiology is not well known. Excessive daytime sleepiness is the major and most frequent symptom. Patients typically present with severe or overwhelming urge to sleep, often in monotonous situations or during periods of relative inactivity. Such episodes may occur without warning and can last seconds to minutes, and these episodes are known as sleep attacks. Naps are short and usually described as refreshing, as is nocturnal sleep. Morning awakening is not difficult. Cataplexy is characteristic of type 1. It is defined by sudden loss of muscle tone during full consciousness, triggered by emotions, especially positive ones, such as laughter or surprise. It can be generalized and lead to falls or can be partial with lower limb collapse, head dropping, or dysarthria. The episodes can last from a few seconds to a few minutes. It probably represents intrusion of REM sleep atonia into wakefulness. Sleep paralysis is a transient paralysis lasting a few seconds or minutes while falling asleep or upon awakening. It is due to REM atonia occurring at sleep onset and persisting briefly upon awakening. It is nonspecific and can occasionally be experienced by 10% of the general population. Sleep-related hallucinations can occur, and these include hallucinations on falling asleep or hypnagogic and on waking up or hypnopompic. As with sleep paralysis, these are more common in type 1. Nighttime sleep is altered and fragmented with multiple arousals. This figure illustrates the phenomenon of cataplexy brought on by a strong emotional trigger, and it can be partial with weakness in the face and neck, or can be total with weakness in the limbs and trunk and cause falls. The tetrad described above is seen only in 40 to 50% of those with type 1 narcolepsy, and usually all four features are not seen on initial presentation. Narcolepsy type 1 is a chronic disease. The severity of cataplexy and sleepiness may improve with age. The clinical course of type 2 is less predictable. Some patients later develop cataplexy and may be reclassified as type 1, and in others the disease may remain chronic and stable. In up to 50% of patients with type 2, the excessive daytime sleepiness may improve spontaneously. Increase in weight is frequent at disease onset, especially in children. Children may also experience precocious puberty. Children can present with paradoxical hyperactive behavior, and the cataplexy attacks may appear without a specific triggering factor. Pathophysiology. Orexin or hypocretin is a hypothalamic peptide that promotes wakefulness and stabilizes the awake, non-REM and REM state. Narcolepsy type 1 is due to orexin deficiency, resulting from loss of orexin-containing neurons in the hypothalamus. This is thought to be related to an autoimmune process, as narcolepsy has a strong association with the HLA-DQB1 allele. Seasonal variations in the onset of type 1 and reports of association with H1N1 infection and H1N1 vaccines support the autoimmune origin. The cause of narcolepsy type 2 is unknown. Orexin levels in these patients are normal. This figure shows the mechanism of excessive daytime sleepiness and cataplexy. In A, neurons that produce orexin help sustain wakefulness by stimulating several wakefulness-promoting neurons in the cortex, in the brainstem, and the basal forebrain. With the loss of orexin-producing neurons in narcolepsy, neurons in these target regions fire less consistently, leading to sleepiness and lapses into sleep. In B, the neurons also excite brainstem regions that suppress REM sleep. Strong emotions activate the medial prefrontal cortex, which excites the orexin-producing neurons, and the amygdala. With the loss of the orexin neurons, imbalance in this pathway inhibits regions that suppress REM sleep, permitting activation of the descending pathways that strongly inhibit motor neurons, and this results in partial or complete cataplexy. Diagnosis. Narcolepsy type 1. This is defined as presence of excessive daytime sleepiness for more than 3 months associated with either number 1, presence of cataplexy, REM sleep latency of 8 minutes or less on the MSLT, and at least 2 sleep onset REM periods during the MSLT, or an orexin level of 110 picograms per ml or less in the CSF. Diagnosis of narcolepsy type 2. This is defined as the presence of excessive daytime sleepiness without cataplexy for longer than 3 months, with mean sleep latency of 8 minutes or fewer on MSLT and at least 2 sleep onset REM periods on MSLT and an orexin level higher than 110 picograms per ml, with exclusion of other causes of excessive daytime sleepiness. This figure shows a typical 8-hour sleep cycle on the left with the various stages of non-REM sleep followed by REM sleep. And on the right, it shows a positive multiple sleep latency test in a patient with narcolepsy. The multiple sleep latency test is indicated in the diagnosis of narcolepsy. It is performed over the course of a day. It consists of 5 nap opportunities given at 2-hour intervals under standard conditions. For each nap, the sleep latency, that is the time from lights out to the first epoch of sleep, and the presence of sleep onset REM periods, that is the first epoch of REM sleep within 15 minutes of sleep onset, are recorded. The MSLT is positive if the following 2 criteria are met. Mean sleep latency of all naps is less than or equal to 8 minutes. 2 or more sleep onset REM periods are present. A nocturnal polysomnogram must be performed on the night preceding the MSLT to rule out other sleep disorders and ensure a total sleep time of at least 6 hours. Treatment: medications for symptomatic treatment. Modafinil, pitolisant, solriamfetol, and oxybates, that is sodium oxybate and lower sodium oxybate, are reasonable to consider as first-line therapy for adult patients with excessive daytime sleepiness. According to European guidelines, monotherapy with pitolisant for milder symptoms or oxybates for more severe symptoms is reasonable to consider as first-line therapy for patients with excessive daytime sleepiness and cataplexy. REM-suppressing antidepressants, in particular venlafaxine and fluoxetine, are used off-label for treatment of cataplexy. Combination of a wake-promoting agent and an antidepressant can be used as an alternative to oxybates. Stimulants like amphetamines, such as dextroamphetamine, and amphetamine-like agents such as methylphenidate, promote wakefulness and have been the mainstay of treatment for many years. They are often used to treat pediatric narcolepsy as they are FDA approved for this indication. This chart shows the drugs modafinil, pitolisant, and sodium oxybate and oxybate salts. It shows their mechanism of action, the usual dose, their indication, common side effects, and monitoring parameters. This chart provides a description for solriamfetol, dextroamphetamine, and methylphenidate, and again provides their mechanism of action, the usual dose, the indication, the side effects, and monitoring parameters. Non-medical management. Scheduled naps are often recommended for people with narcolepsy type 1 because short naps are usually restorative. The combination of scheduled naps with regular nocturnal sleep scheduling can provide significant benefit. All patients with narcolepsy and uncontrolled sleepiness should be warned about the possible risks of driving while impaired and instructed not to drive when drowsy.